mainly two. A. Minimize infection during labor. B. Avoid bladder rupture during the third stage of labor. C. Prevent contamination during the second stage of labor. And D. Avoid complications during the second stage of labor and the third stage of labor. So let's send in our answers for number 61. So I'm saying it's good D. Number 61, I'm saying it's good D. That is avoid complications during the second stage of labor. Yeah, they do say a full bladder causes what? Is it a full bladder causes what? Somebody remind me kindly. Kuna kitu ina cause nimesahau. Just forgotten it slightly. Attorney. Yeah, so tuendelee to number 62 if you're good there. Unaweza tuma number 62 tuendelee. Alafu yeah, Jill says uterine attorney. Thank you. Kindly somebody atusaidie kuupdate pia the score sheet. Number 62. Ductus arteriosus is a bypass in the baby circulation form. A. Umbilical vein to the inferior vena cava. B. Pulmonary artery to the aorta. C. Left atria to the right atria. And then D. Internal iliac artery to the umbilical artery. So let's send in our answers for number 62. Uh, 62 I'm saying let's go with B. So somebody can just send there are other connections. Umbilical vein to the inferior vena cava ni gani? Zoo says C ni foramen ovale. Okay, sawa. So si mnaweza tuma tuje some evidence. I think it's pinned somewhere up there. Mnaweza tuma some evidence tuangalie tu fetal circulation mbio mbio. Fetal circulation. So the ductus arteriosus, this one connects the pulmonary artery to the descending aorta. Foramen ovale connects the right atrium to the left atrium. Then the ductus venosus, this one connects the umbilical vein to the IVC. Transition to neonatal circulation. There's a dramatic increase in SVR caused by removal of the placenta, inflation of the lungs, and increase in endogenous nitrogen oxide. This leads to decrease in PVR. Persistent fetal circulation. One, hypoxia, hypercarbia, and increase in PVR. You have DA dilatation. The dilation that is I don't know, secondary to lung shunting something. So thank you for that, Ivy. Okay, so that's just something shortly on the fetal circulation. It's and then Zoo anauliza the closure time. Mnaweza mkumbusha? So she anasema the ductus venosus closes within 1 to 3 weeks, then ductus arteriosus closes within 4 to 3 weeks, 4 to 8 weeks, that is, sorry. Thank you for that, Shiv. So TYY needs some clarification. Yeah, there's always the functional closure. There's the functional closure na kuna anatomical closure. Oh yeah, actually ziko hapa juu ni vile sasa ni vile sikuzisoma. So the ductus arteriosus, this one closes 4 to 8 weeks. Yeah, closes 4 to 8 weeks. Then the ductus venosus closes within 1 to 3 weeks. So tuko sawa hapo. Are we good? Tuendelee. You good? So naongeza forward number 63. Tuendelee. Kindly nishikilie kidogo hivi. I'm making some call, I'm coming back.
63. A reduction in urinary output in prolonged labor may be associated with antidiuretic effect of the oxytocin, pyrexia, and dehydration. Then dehydration, pyrexia, and diarrhea. Antidiuretic effect of oxytocin, pyrexia, vomiting, or diarrhea, pyrexia, and vomiting. Tushel ashasema ni Michelle na Black Potion washaanza kuleta mapenzi. Zua na question C. Tungi asema I think itatoa C ni vomiting. Kwa prolonged labor ako likely kuvomit kweli? Vomiting na diarrhea ndo I think itatoa, or vomiting X ya na diarrhea pia X. Sawa. Mapenzi kati ya Zoo na Swifty. Michelle anasema mko sure vomit. Mko sure vomit? Mko sure? Sijui, naweza nisupport. Washana wakivomit, not everyone. Okay. Sawa. Aya,
Back.
260. Oh, sawa. Thank you. Endelea.
Thank you for kunishikilia. Appreciate. So so tuendelee. I hope alifanya the previous number. So you can kindly forward number 64. Tuendelee. So 64, in a normal delivery with a well-flexed head, the presenting diameters are A, metavertical 13.5 and bitemporal 8.2, B, bitemporal 8.2 and submetabrachmatic 9.5, C, bitemporal 9.5 and suboccipitobrachmatic 9.5, B, bitemporal 9.5 and occipitofrontal 11.5. So let's send in our answers for that. So here to go sawa. Same as go with C. Okay, so the next number. '65. The maternal characteristics are midwifery used to diagnose late obstructed labor through a pathograph include A. Slow cervical dilatation, pyrexia, excessive molding, and B. We have rapid pulse rate, pyrexia, excessive molding. C. We have slow cervical dilatation, excessive molding, and oliguria. And then D. We have rapid pulse rate, pyrexia, and oliguria. So let's send analysis. So use midwife, which one used to diagnose late obstructed labor through a pathograph. So there's an answer sent here. I guess this was number 63. No, number 63. Ilikuwa inauliza reduction in urine output in prolonged labor may be associated with. So the correct answer is C instead of A. So I guess you guys went with A, but it's calling to confirm the correct answer is C, and C is antidiuretic effect of oxytocin, pyrexia, and vomiting. So the rationale: during prolonged labor, a patient may develop oliguria due to the following reasons: the diuretic effect of oxytocin, fever that leads to sweating and loss of fluids, and losses through vomiting. So number 67, number 60, wait, number 65, number 65, I'm seeing us go with C, and David is going to B. Well, first of all, mko sawa na these, are you guys contented na hii nini ya med scholar? Hii jibu ya med scholar? Or we need to go back to the question and look at it deeply? Like before we go to number 65, mko sawa na hiyo jibu ya med scholar ya 60, was it 63? I guess so. Are you guys okay with it? Are you contented now? All right. So I was to ask the same question. Felipe unataka evidence ya which number? And Ivy says, I think it's okay because dehydration results from vomiting and diarrhea. So that means we are okay. Number 63 as C. So tuendelea na 65, huh? Okay, Tuchel says, one thing I know, vomiting can cause fluid loss, but it's less frequent or severe in prolonged labor compared to dehydration from other causes like fever and poor intake. Okay, so let's send in our answers. Let's keep on sending our answers for number 65. Nilishaona B and B and C. B ilikuwa rapid pulse rate, pyrexia, excessive molding, and C is slow cervical dilatation, excessive molding, and oliguria. So which is which? Okay, so obviously tuangalia both early and late signs. Then Dave says rapid pulse haiwezi kuwa determined kwa photograph. Nimeona sawa. So there's something sent here by the portion. So let's go through it. So diagnosis of obstruction of labor. So we got the early signs. The presenting part does not enter the pelvic rim despite good uterine contractions. And then the cervical dilates slowly and hangs loosely like an empty sleeve due to poor application of the presenting part. The membranes tend to rupture quite early. The late signs, we have the fetal and the maternal distress, which occur concurrently. Then the constructions are hypertonic and the mother does not relax in between them. The uterus is molded around the fetus. Then the mother may have pyrexia and tachycardia. On vaginal examination, there's presence of a large caput. Then the vagina feels hot and dry, and the cervix and the vulva are edematous. In cephalic presentation, the presenting part becomes vague and immovable when it descends partly into the pelvis. Then it is difficult to pass urine if catheterized. The urine is blood-stained due to bruised urethra. The urine output is poor. Then uterine exhaustion occurs and the contractions cease for a while, only to remain with renewed vigor, especially in priming gravida. A Bartle's ring is seen abnormally at the lower segment and is progressively enlarged and thinned out, and the upper segment becomes short and thick. So we've seen that. Then Dave says pyrexia is a node from temperature monitoring. Okay, so from that evidence, so or what's our answer, guys? Is it B or C? So Dave says, oh, Dave has a question. Nauliza niko na swali. Rapid pulse haiwezi sema iko more than 100 in 1 minute. So Remo says that makes B and C the choices. Black Potion says D. Felipe says D. Then Ivy says dilatation ni early. So Lucy Mora says D. Molding is a fetal characteristics. And then the question B. So basically molding the fetal characteristics actually. So there's a photograph sent here. Unawezaona vizuri the components are the photograph. And then Ivy says it's not B juu wameuliza matano. Your phone is tuangalie Pyramid Scholar. So it's D, yeah? It's D. Is it D? So tuendelee na D. So are we all good with D? No. All right. So let's afford the next number. Fortunately, my scholar says the correction is C. So let's see the rationale. The following features are seen in obstetric labor on general examination. So general examination signs, we have maternal exhaustion, signs of dehydration, and signs of dehydration. Signs of abdominal exam, we have the uterus is hard and tender. Then the patient has tetanic contractions, that is the hyperactive uterine contractions. Then there's formation of a retraction ring. Fetal heart rate shows fetal distress, that is tachycardia and irregular bradycardia. And then there's no or little progress in fetal descent. Then signs on vaginal examination, the vulva is edematous, the vagina is dry and hot, the cervix partially dilated, edematous and hanging, then may also be fully dilated. The presenting part is high and not engaged or impacted into the pelvis. The head has a large caput succedaneum and severe molding. So, okay, so are you guys contented na hiyo? Are you guys contented na hiyo? Ama D has more weight? No, it doesn't really make sense at all. So for number, it was number 65, huh? When you have an update score sheet, you can just put D, then you start though, because in a contradict na yung scholar. Okay, so C20 little number 65, huh? So 65, huh? Maternal causes of shoulder dystocia include maternal causes. I hope nobody's left behind on the previous question. Maternal causes of the shoulder dystocia include A, lax uterine muscles, uterine abnormality, B, we have contracted pelvis, gestational DM, C, we have lax uterine muscles, multiple pregnancy, and D, we have uterine abnormality, multiple pregnancy. So let's send in our answers for number 66. So I'm saying B and A, and B is contracted pelvis, gestational diabetes. A is lax uterine muscles and uterine abnormality. Then black portion says any shoulder dystocia, shoulder presentation, that is, and then B ndo shoulder dystocia. So we can get some evidences on this. We can get some evidences on this, then we go through it. So you guys can send in something on it to PTA. Okay, so there's some evidence in here by Manuel. Thank you. So let's go through them. Complications of dystocia. So we have maternal, then we have postpartum hemorrhage. This is the commonest one. Is about and accounts for about 11%. And then we have rectovaginal fistula because of of a difficult delivery. That is, we have symphyseal separation of or diaphysis with or without transient femoral neuropathy. And then we have third or fourth degree episiotomy or tear with anal sphincter damage. We also have uterine rupture, then soft tissue injuries. We have brachial plexus palsy. This is the commonest. Now this was the maternal one. Your PPH, your fistula, the uterine rupture, and the soft tissue injuries. And then we have the fetal now. So we have the brachial plexus palsy. This is the commonest and accounts for about 3 to 15%, especially the Erb's palsy and the Klumsky's palsy. We have the cervical fracture, and then the fetal death, fetal hypoxia, with or without permanent neurological damage. Then we have fractures of the humerus. There's another one sent here. So the causes, I guess the causes are dystocia. Yeah, so causes the maternal. So
hizo ni nini? Ni consist shoulder presentation, not shoulder dystocia. And then a distortion hapo chini.
Thank you for that correction. So the presentation venye who was talking amesema, whoever was talking amesema. So the maternal, we have the hydramnios. This one is the distended uterus, is globular in shape, and fetus can move freely in the excessive amniotic fluid volume. Then we have the macerated fetus. Lack of muscle tone causes the fetus to slump down into the lower pole of the uterus. Then we have placenta previa. So this may prevent the fetal head from entering the pelvic brim. Other maternal causes. So we have the lax abdominal uterine muscles. So let's note this. This is the most common cause and is found in multigravidae, particularly those of high parity. We have uterine malformations, and then we have contracted pelvis. For the fetal end, tuko na preterm pregnancy and the multiple pregnancy. So that is it on the shoulder presentation. Then now the dystocia. Dystocia, we have risk factors. So tasoma tu hapo penye imekuwa underlined. So antenatal risk factors include diabetes. We have postpartum pregnancy, high parity, maternal age over 35, and maternal obesity, that is weight over 90 kgs. Okay. There's another one sent here by Emmanuel. So predisposing factors, maternal, we have abnormal pelvic anatomy. Then we have gestational DM or maternal obesity. Then we have post-date pregnancy, high parity, maternal age about 35 years, previous dystocia, short stature, then high pre-pregnancy weight and increased weight gain. That is a BMI greater than 25, and BMI greater than 25, this is equal to maternal obesity. On the fetal end, we have suspected macrosomia. On the labor-related, we have assisted vaginal delivery, either through forceps or vacuum. We have protracted or prolonged active phase of the first stage, then protracted second stage of labor, then a prior shoulder dystocia. Okay, so from the evidences that we've looked at, so what's our answer, guys? Which should we go with? Which answer are we going with? And Ray, Ray says it's caused by gestational diabetes, which is maternal. Then Nemo says how akina mama wa above 35 years wako at risk ya kila kitu. So 66B, right? Yeah, so tuendelee. Alright. Number 67. To prevent neural tube defects, the midwife advises a woman planning to conceive to take vitamin B12, B vitamin A, C ferrous sulfate, and D, folic acid. So which one do you use midwife advise a woman planning to conceive to take to prevent a neural tube defect? Let's send in our answers for that. So singers go D is also straightforward. So tuendele. And on is number 68. Number 68. The milk secreting cells in the breast are referred to as the male secreting cells in the breast are referred to as A. We have acini cells, B. Myepithelial cells, alveolar cells, and montogometry tubercle. Nimo says jitayarishe na hivi anasema nishaanza mapema. Yeah, we've prepared enough for the exams, so we're good. I think we're gonna pass. Number 68, I'm saying let's go with A, acini cells, and C, Tushel and C. C is alveolar cells, and there is also B. B is my epithelial cells. So let's get some evidences on this to PTA. Let's get some evidences on this. We go through it. And then Bobby says, acini milk. Acini is responsible for milk secreting. Is milk secreting cells? Alafu lactiferous. This one transports milk. Tushel says milk producing cells, CO alveoli. Oh, that's a question on our list of the class. So let's send some evidences on this, then we go through it. Yeah, so obviously is tuangalie the anatomy ya breast mbio and Zoo says montogometry. This secretes sebum to lubricate the areola. So let's send something on it to PTA. Actually, let's just look. So IV sent something. The acini milk secreting cell, like lactiferous, this one transports milk. Montogometry secretes sebum to lubricate areola. So kuna ka evidence kametumwa hapa. I'll just read the cycle, the one from the mics. Into some of the cycle part. So in some of the alveoli contain milk producing acini cells surrounded by my epithelial cells, which contract and propel the milk out. The small lactiferous duct carrying milk from the alveoli unite to form the larger ducts. Okay, so thank you for that. Then the speed is sent something on the anatomy of the lactating breast. So we have the alveoli. This one contains acini cells, which produce milk and are surrounded by my epithelial cells. So note that the acini cells produce milk na ziko kwa alveoli, na ziko surrounded by my epithelial cells, which contain NAD which contracts not propel milk to the nipple. And then we have the mammary glands. The mammary glands are compound tubuloalveolar glands. Then they have about 15 to 20 lobes that radiate out from the nipple, separated by the collagenous connective tissues. So these lobes drain into lactiferous duct, which expand to form a lactiferous sinus for milk storage. The third one, we have the nipple, the central area through which milk ducts open, and is composed of erectile tissues. The fourth one, we have the areola. This is the area of pigmented skin which surround the nipple. It contains montogometry cells, montogometry glands. So you'll call space, so let's note it. That produces sebum-like substance. I think somebody said something on it. Sebum-like substance, which acts as a lubricant during pregnancy and breastfeeding. Then the fifth one is fat. This one contains 80 to 85% of normal breast in fat. In late pregnancy, the fat is replaced by the glandular or milk cells in readiness for lactation. The fat gives the breast its shape. So you can be able to see. So 1 represents the chest wall, then 2 is the pectoralis muscle, 3 is the mammary gland or lobes, then 4 is the nipple, 6 is the milk ducts, then 7 is the adipose or fatty tissue, 8 is the inflammatory fold. Yeah, so you can see that clearly. Okay, so animal release and hormones production or secretion. So prolactin, P for then letdown is oxytocin. Nyaboke says milk secreting cells in the breasts are known as lactocytes. These specialized epithelial cells are responsible for mammary glands and are responsible for production and secreting milk. They are also referred to as alveolar cells. Then MJE sent something. The alveoli contains milk producing acini cells. So tunezona, that's acini. There's another evidence sent here, so let's just go through it. When the infant suckles, sensory nerve fibers in the areola trigger a neuroendocrine reflex that results in milk secretion from the lactocytes into the alveoli. The posterior pituitary releases oxytocin, which stimulates the myoepithelial cells to squeeze milk from the alveoli so it can drain into the lactiferous duct, which collects in the lactiferous sinuses and discharge through the nipple pores. So it takes less than 1 minute from the time an infant begins suckling, that is a latent period, until milk is secreted, the letdown. The image below summarizes the positive feedback loop for letdown reflex. So mnazaona hiyo image venye ananyonya na the suckling itself triggers the anterior pituitary brain, receives, so the suckling itself triggers the brain and receives sensory impulses from the areola and releases oxytocin from the hypothalamus and the posterior pituitary glands. So hii sasa ndo inaleta that process ya milk letdown na maziwa kufikia mtoi. Okay, so then Tuchel says, okay, so alveoli cells are the same as acini cells, but specifically acini cells. Yeah. Speed, if you can send the book, kuna msama request to make kitabu hapo. So you guys, are you good? Wait, what's the question asking? So see, tuendele. So tumeona it's the acini. Yeah, so let tuendele to the next question. You can forward the next question, tuendele. So number 69. The midwife formulates the following nursing diagnosis for the mother who develops hypovolemic shock after uterine rupture. A. Fluid volume deficit related to intrauterine bleeding as evidenced by vaginal bleeding. B. Risk of fluid deficit related to uterine rupture. C. Impaired tissue perfusion as evidenced by blood loss. And D. Ineffective gaseous exchange related to uterine rupture. So let's send in our answers for number 69. How would you as a midwife intervene or formulation nursing diagnosis for a mother who develops hypovolemic shock secondary to uterine rupture? So 69, I'm saying let's go with there. And A is fluid volume deficit related to intrauterine bleeding as evidenced by vaginal bleeding. Okay, so students, and to the next number. So number 70. Maternal distress can be diagnosed from the patograph through A. Cervical dilatation, uterine testing, and blood pressure. B.
Mwenda nikaa January 69.
Somebody's left behind. Okay. So sikuwa nimeona. I'm very sorry, Black Portion, for that. Okay, you unaweza tupatia the reason as to why unaenda na C? Unaenda na C.
Okay, we've been told already the mother has hypovolemic shock. So I don't think fluid deficit will take priority to impaired tissue perfusion, because if you define shock itself, it is the impaired tissue perfusion. So I think what will take precedence is impaired tissue perfusion as compared to fluid deficit, though fluid deficit equal.
So med scholar imetumwa hapa na wanasema the corrections is C, that is impaired tissue perfusion as evidenced by blood loss, not A venye Black Portion alikuwa anasema. So the rationale is in shock, that is impaired tissue perfusion. In this patient, she has lost a lot of blood, and therefore impaired tissue perfusion is due to blood loss from. Okay, so Hector says, Hapa, we are more concerned with bleeding. That is what we focus on, that's priority. And thank you for that, Black Portion, by the way. So Melonite C impaired tissue perfusion.
Let me explain why I think Nisi. Already tumeambiwa, like kwa swali tuliambiwa the mother has hypovolemic shock and it's due to uterine rupture. So meaning uterine rupture ndio may cause bleeding and it has led to hypovolemic shock. C says impaired perfusion as evidenced by blood loss. So see, like hypovolemic shock is diagnosed by a mother who's bleeding. So definitely alikuwa na blood loss. So you can use that as an evidence to show that this mother has lost a capacity ama like the vascular volume. Ndio maana akapata shock. So you can evidence it as that blood loss. It's part of the pathology and ina underlie the hypovolemia. Something maybe more descriptive ingekuwa maybe like a copella, akona low oxygen saturation, that would be more conclusive. But according to the pathophysiology, the pathology ya uterine rupture, I may lose blood. Yeah, so hivyo ndo mi nilikuwa nafikiria. Tushel cyanosis inakuanga problem. Cyanosis inakuanga the associated factor if the problem is respiratory. But if the problem is circulatory, the evidence factor can be the blood loss itself, can be poor saturation, can be low hemoglobin levels, something relating to the heart and the cardiovascular system. That's how I understand. But cyanosis inakuanga kwa kama ni the problem ni respiratory. Napatanga maybe wanasema impaired gaseous exchange as evidenced by central cyanosis ama as evidenced by maybe hakuna lung sounds kitu kayo. That's how I understand it.
So thank you for that clarification, Black Person. So let me read something here. Inaanzia hapa kwa pathophysiology of shock. So the sequence of events in hypovolemic shock begins with decrease in intravascular volume. So this results in decreased venous rate of blood to the heart and subsequent decreased ventricular filling. Decreased ventricular filling results in decreased stroke volume, that is the amount of blood ejected from the heart, and decreased cardiac output. When cardiac output drops, blood pressure drops, and the tissue cannot be adequately perfused. So I hope none of that from that pathophysiology. So to show me the next slide. Shock can best be defined as a condition in which widespread perfusion to the cells is inadequate to deliver oxygen and nutrients to support vital organs and cellular functions. So I hope the evidence of Black Person will make a lot of sense. Okay. If we look at the structure of nursing diagnosis, and I honestly also don't feel like it applies in this, because hata nikiangalia the option, let's go back to this one. See, nursing diagnosis is kuanga na the problem. Let's say, for example, tuchague 2A, the problem is fluid volume deficit. That's the problem. Then the etiology, what's causing this fluid volume deficit? So is it like fluid volume deficit related to intrauterine bleeding, as evidenced by vaginal bleeding? Makes sense. But then I don't really think it applies kwa MCQs per se, like ni lazima ufuatilie as in ile hiyo the three system, like the problem, etiology na the defining characteristics. Now when you come to see, you can have the problem, yes, the impaired tissue perfusion, but then haina etiology, because it's assuming that etiology, it's getting its etiology from the question. Na question ilikuwa nauliza, the midwife will formulate the following nursing diagnosis for a patient who develops hypovolemic shock after uterine rupture. So it's assuming that its etiology inatoka maybe from this hypovolemic shock or uterine rupture, secondary to secondary to hypovolemic shock, secondary to uterine rupture. So that's why you can have the two parts. So I guess BP made sense on that. Iko sawa tu Chel, iko sawa, but sasa and then there is also that aspect ya ABC. Oh, by the way, even if you look at it from that aspect ya ABC, it really makes sense. Yeah. Si tuendele. Si tusiti. So Dave anasema bado kidogo sielewi mbona anasema haifuati the three part kwa ground ukiandika such a diagnosis itakubalika. You can talk Black Potion, you can talk.
Okay, sijui kama like maybe in your exams zenye mulikuwa mnafanyanga, I realized something in most of the questions, kama ilikuwa MCQs, they weren't really keen about that construction ya the three parts. Most of the time maswali nimepatanga, like sometimes they don't really follow those rules nile they expect such from us. So I don't know, mimi like singe go to that level as long as they this is how I take it, as long as the related part ni correct, hata kama sijapewa the evidenced by, ama kama nimepewa as evidenced by na sijapewa the related part, as long as it's true, I would go with the choice if it's the best answer for me, unaona. Alafu Tushel, impaired tissue perfusion is not related to the blood loss. Like kuna venye inasemwangwa in such a scenario, maybe wangesema impaired tissue perfusion related to loss of the vascular capacity, kitu kama hiyo. They don't really use your blood loss, haitumikangi directly, kuna venye inasemwanga. Anyway, let me not complicate, but even ndo nimekuwa nikiobserve, even for the questions zenye nimekuwa nikipatana nazo, they don't really follow your structure ya the three part of a diagnosis that much. And you realize sometimes kama like if you look at the rest of the responses, haziko complete. Ineffective gases extent related to uterine rupture, they haven't given the three parts. But as long as evidenced by loss, blood loss is okay, it's cool. Me, I feel hivyo.
So are you guys satisfied? Tumeka sana your number. I think we've spent more than 10 minutes kwa your number. Ama alternatively, kama you guys are not satisfied, unaweza eka is it LC? Yeah, you can put both of them, then you star. Yeah, so number 70. Maternal distress can be diagnosed from a patograph through A, cervical dilatation, urine testing, blood pressure. B, urine testing, blood pressure, maternal pulse. C, cervical dilatation, urine testing, amniotic fluid. D, cervical dilatation, uterine contractions, and blood pressure. So let's send in our answers for that. So number 70, I'm seeing as go with B. And B is urine testing, blood pressure, and maternal pulse. So nyachoma anauliza urine shows. Hector says kwa hemorrhagic shock tutapeana blood ama fluids. I think it's a mixture of both. Like it'll depend pia na HB zake, because you don't want to cause hemodilution. Utaki kupeana fluids mingi you cause hemodilution na pia kitu kama hiyo. So it'll depend pia na HB zake. Ivy says I don't have anything against B, but mtu anaweza niambia urine testing how, please. And Bobby says ketones, Felipe ketones, Dave ketones too. Nemo says I think there will be ketones. Black Ocean says inakwanga hapo chini kwa patograph amount of urine output pia. Then Ivy says as in ketones na distress how tena. So okay, according to my thinking, si ketones zionyeshanga nini dehydration. So in a state whereby especially mother akiprogress to tuseme kitu kama second stage ama akiwa tuko hiyo phase ya labor, from what I saw in the labor ward penye nilikuwa, they're always overwhelmed and stuff. So saa zingine unapata hawakuli, they usually have prolonged starving ama fasting, kitu kama hiyo, they don't really eat. So the body ina switch from glucose to fat metabolism, so hii ina produce ketones. It's just that process ya metabolism from glucose to fat metabolism, that process you're switching from glucose metabolism to the fat metabolism yenye ina produce hizo ketones. So me I don't, that's just according to my thinking though. Then Bobby says ketones occur during labor, primarily due to prolonged fasting, increased energy demands, and stress. And then there's another one sent here by Spader. Let's go through it. Maternal distress. So this occurs to maternal. This refers to maternal exhaustion, when the strains and stress for labor are proved beyond the mother's capability. It can occur at any stage of labor, though rare in the first stage, and is an indication of termination of labor. Maternal distress is anticipated in trial of labor, induction of labor, malpresentation, abnormal position, early primary gravidas, those with cardiac disease, pulmonary tuberculosis, diabetes, severe hypertension, preeclampsia, eclampsia, and severe anemia. The signs of maternal distress include: one, we have increased pulse rate, that is 90 to 120 beats per minute as an early sign. Then we also have rise in temperature. There's increase in respiratory rate of 24 breaths per minute and above. Then there's a sense of dehydration, which will be seen as a dry, furred tongue or dry skin and presence of acetone in urine. There's also distension of the bowel, the gas, there's vomiting, there's restlessness, so the patient looks ill, anxious, and worried. So how do you manage maternal distress? The mother should be booked for hospital delivery, and preventive measures taken such as adequate rest, hydration, and avoidance of prolonged labor. We have sedation or assisting of the delivery by episiotomy when in second stage. Then termination of labor, which depends on the condition of the mother and the degree of cervical dilatation. Where the cervical os is less than 6 centimeters dilated, C-section is done. The forceps on the episiotomy are used to hasten the second stage when the cervix is fully dilated. Okay, so then about portional laser communications in relate with diabetes, but obviously it's not necessarily for every woman. So the chama says so to semage maternal distress and urine contents relate. Yes. Now, venye ni mama sema hapo chini moso ketones. So do we go with the ketones in urine? Do we go with the with B? Do we go with B? So are you guys okay to endelea na B? Okay, so city unaweza tuma the next number. Then black question says ukitumia alafu pia ukitumia elimination unatoa cervical dilatation. Okay, so number 71. The direct causes of maternal deaths in Kenya include A, hemorrhage, eclampsia, sepsis; B, hemorrhage, malaria, sepsis. So malaria natoa hiyo B. C, malaria, anemia, sepsis. Malaria natoa C. D, malaria, anemia, hemorrhage. Malaria natoa D. So 71 is A, so that's straightforward. I don't think we need to waste a lot of time there. Unaweza tuma 72 tuendelee. 72, maternal minor complications which may occur during puerperium. Maternal minor complications which may occur during puerperium include A, cracked nipples, breast engorgement and bleeding. B, depression, cracked nipples, sore perineum. C, we have sore perineum, engorged, cracked, engorged breast and cracked nipples. D, we have depression, engorged breast and bleeding. So let's send in our answers for number 72. Let's send in our answers for number 72. This is gonna be C, yeah? That's gonna be C for sure. Anyway, penye tumeona bleeding definitely removes that, and even, yeah. So it's C, sore nipples, engorgement and cracked nipples. So there's a tumor 73. Definitive indications for elective CEs include CPD, major degree of placenta previa. B, we have CPD, breech presentation. C, we have high order multiple pregnancies and breech presentation. And D, we have major degree of placenta previa and DM. So what are the definitive indications for elective CEs? I'm saying let's go with A, except James who goes with C. So A is cephalopelvic disproportion. They have major degree of placenta previa, and C is high order multiple pregnancies and breed pregnancy. Oh, I'm correct. A. So that's the EU to saw A. But there's a 274 to delay. Unless there's somebody who has a contradicting answer. Are we good to delay? 73 is A. So 74. 74. In the management of accident victims, the golden hour refers to the first hour from the time of A, the patient arrival to the hospital, B, trauma impact, C, initial emergency rescue, and then D, we have complete triage. So I'm seeing B and C. I'm seeing B and C. B is trauma impact and C is initial emergency rescue. So it is in something. The golden hour in trauma refers to the first hour after traumatic injury, a critical period during which prompt medical interventions significantly increases the chances of survival and reduce the risk of long-term complications. So I think it's B. B kind of makes sense. So I'll call you L. I'll call you L. Just allow me to call you L. L said the golden hour in trauma causes trauma care refers to the first 60 minutes after a traumatic injury. So this is the critical window during which prompt medical treatment significantly improves the chances of survival and recovery. It begins at the time of trauma, that is the impact, not upon hospital arrival and triage. And then Bobby sent another one here. The golden hour, this is the average amount of time that elapses before a patient with a series of multiple injuries starts to deteriorate rapidly. For every 30-minute period after golden hour, the patient chances of survival are cut in half. Thank you for that, Bobby and Al. I've just said something down here. The first 60 minutes after traumatic injury, this is the most crucial period that determines the patient's outcome. That has been termed the golden hour. The concept that definitive resuscitative trauma care must be initiated within the early window has been publicized, taught, and practiced worldwide for more than 4 decades. There's another one set down here. The first hour, that is the golden hour. The first hour after the onset of out of hospital traumatic injuries referred to as the golden hour. Yet the relationship between the time and the outcome remains unclear. Okay, so it's fine. So tuendelee na B. Tuendelee na B. Seen enough evidences on it. The part of an artery that has smooth muscles and elastic tissues. The part of an artery that has smooth muscles and elastic tissues. A, the artery end plate. B, tunica adventitia. C, tunica intima. And then we have tunica media. Something is good. D, tunica media. That seems easy. Kuna contradicting answer. Number 76 inaweza tuma 76 tuendelee. The right diet for a client with cholecystitis includes A, high calorie and high protein, B, low fat and low protein, C, high protein and high fats, and then D, high fats and low protein. Let's send in our answers for number 76. So that is low fat and low proteins. Hiyo naona tuko sawa. Naweza tuma 77 tuendelee. First morning specimen of urine is ideal for screening purposes because the patient mostly passes urine in the morning. B, of eat low concentration substances. C, large amount of urine void in the morning. And the D, of high concentration of substances. So let's send answers for 77 too. Tunaweza tuma 78 tuendelee pia. 78. One of the reasons avoiding strong sneezing and coughing post-cataract surgery, post-cataract extraction is to prevent increased intraocular pressure. B, prevent cross-infection spread among the patients. C, prevent nose bleeding from blood vessels supplying the eyes and the nose. D, ensure that the patient adheres to preoperative instructions of the condition. I'll listen for 78 tutume pia majibu. Something is good there. Is prevent increased intraocular pressure. And then zoo, as I said, but see how it can dislodge to vitreous. So tunaweza endelea to number 79. Listen, number 79 tuendelee. The universal first step in infection prevention is to A, disinfect working surfaces before the procedure. Not really. B, isolation of infectious cases outside the remaining ward. C, use protective gears, and D, regular hand washing. That's straightforward. Unaweza tuma namba 80 tuendelee pia. The term idiosyncrasy in pharmacology means A, improper drug use, B, abnormal sensitivity to drugs, C, overdose of drug, B, and D, underdose of a drug. So just send in our answers for number 80. That's also straightforward. Is the abnormal sensitivity to drugs. So Nizatoma number 81. So number 81. The pain in angina pectoris is primarily due to A, coronary vasoconstriction, B, coronary vasodilatation, C, myocardial infarction, and D, portal hypotension. Let's send in our answers for all that. Okay, so for number 81, I'm seeing C, and then I'm also seeing A. So A is coronary vasoconstriction and C is myocardial infarction. So let's send something on tutume tutafute kitu na angina pectoris to tuipitie, since we have different answers on this. Let's send something on this. Jesus.
Ni kama Mola ameenda. Okay, so see the answer
I'm
is
here.
C.
I'm here.
Oh, you back?
No, I've been here. So see, I'm going to just automate something on, because it one I'm seeing different answers on. I'm going to automate something on angina pectoris. So so Emmanuel says beer coronary vasoconstriction echo, but major HIC. Okay, so And then Zoo says not vasoconstriction causes ischemia, which causes angina. So the corrections according to Med College C, the patients with angina pectoris present with chest pain. So this is due to ischemia to the cardiac muscles caused by inadequate blood supply. That is a myocardial infarction. Now that the question is asking the causes of the pain and not the cause of inadequate blood supply to the heart. So inadequate blood supply to the heart is due to coronary vasoconstriction. So wase walikuwa nasema that's basically inadequate blood supply to the heart. Yeah, so I hope you may know that. Radices infarction is an area of dead tissues. I thought of vasoconstriction leading to ischemia in prolonged inhalator infarction. So tunaweza endelea to the next question, number 82 imetumwa hapo juu. Number 82, the role a senior nurse should play in preparative settings is, I think hii tulipitia the other day. Anyway, let's send in our responses for that. Senior nurse should play in preparative setting is A, circulating nurse, B, receiving nurse, C, recovery and D, scrub nurse. I think in the medical field, it's just all about the experience. The age doesn't really matter. Like msana za kuwa younging, but they got more experience than like an older person who decided like anafanya accounting then shifted to nursing. So you see, the younging is like any experience or rather chuo yenye uko nayo, like education level. So the youngin is older than that person kwa the field. So I'm seeing A, C, and D. But we see the correct answer is scrub nurse. If I'm not wrong, if I remember very well, you said the correct. Okay, I don't know. Maybe as a confound med scholar before, but I remember to list some other corrections. I was a scrub nurse. Yeah, because we looked at it at that time. Yeah. So Zoo says D because she is more experienced and can carry out complex duties. Then Tuchel says due theta is in sterility, so non-pair circulation. Popper had some thoughts. It's also connection for sure. Your phone is a tuangalia med scholar, then tuendelee. Med scholar says D. In the preparative setting, the senior nurse should serve as a scrub nurse who is electing and passing instruments and supplies used for operation to the surgeon. So hapo umeona hiyo. Anaweza tuma namba 83 tuendelee pia. The average incubation period of hepatitis B viruses A 3 to 7 days, B 10 to 15, C 15 to 30, and D 60 to 90 days. Let's send in our answers for that. In the meantime, 22 answers 8 to 4, number 83. Emmanuel has sent something here. A scrub nurse. This one maintains sterility within the sterile field, prepares instruments and equipment, assists the surgeon during the procedure by anticipating needs and handling instruments, counts sponges, instruments, and needles, maintains meticulous records of the procedures. Then the circulating nurse, this one oversees the overall patient care and surgical environment, and then also verifies patient identity, confirms surgical site, and ensures consent. Manages the flow of information, supplies with the OR. Then also works as a patient advocate and ensures safety. Documents all events during the procedure. Then may have supervisory responsibility for the other teams. Thank you for that, Emmanuel. So the three singers go with D. That is 60 to 90 days. 60 to 90 days. That's like we go sure. And Tuchel says, but Kenya walikuwa circulating water. Necessity tulikuwa scrub. However, Bobby says it's A, 15 to 50 days. Oh, yeah, hepatitis A ni 15 to 50 days. Okay. So number 83 naona tuko sawa na D, unless there is anybody who was a contradicting answer. Tunaweza endelea tu number 84. Unaweza tuma number 84. Tuendelee. Factors that determine the severity of burns on human beings include A, the depth of the burns and skin integrity. B, extent of depth of burns. C, source of heat. This D, specific part burnt. Then James anauliza ya hepatitis C, na Emmanuel ana request kama tunaweza angalia the incubation for the other strains. So meanwhile, as we send in our answers for number 84, we can also look for the incubation period at the other strains. So 84 I'm also saying as go with B. These are extent and depth of burns. That's also straightforward na tulipitia the other time. So kuna ingine hapa imetumwa na Wildflower. It's kind of unclear, so sijui kama unaweza, but so hata tu ni maneuver to around it. So hepatitis A takes around 50 to 50 days. Hepatitis B takes around 28 to 160 days. Hepatitis C 15 to 160 days. D 21 to 140. E takes around 15 to 65 days. So I hope umeona hiyo Emmanuel. Number 84 tuko sawa na B. Tuendelee. The extent of death of burns. I hope nobody has a contradicting answer and everybody is good na B. So 85. 85. Nephrotic syndrome presents with A, increased albumin in blood, loss of protein in urine. B, high serum cholesterol, presence of blood in urine. C, decreased albumin in blood, high serum cholesterol. D, loss of albumin in urine and presence of blood in urine. So let's send in our answers for nephrotic syndrome. For number 85, that is not nephrotic syndrome. Some sinners go with C. C is decreased albumin in blood and high serum cholesterol. So obviously the hematuria is nephritic syndrome. Then Zeus is hypoalbuminemia and proteinuria and hyperlipidemia. So yeah, nephritic glomerulonephritis Tushel. Hematuria hukua kwa nephritic syndrome James. So tuendelee to the next number. Kunaweza tuma the next number tuendelee UFO. Kuna ingine imetumwa hapa na Philippe, nephritic and nephrotic syndrome. So for the nephritic syndrome, we have the inflammation of the glomerulus. So we have signs like hypertension, colored urine, hematuria. We have oliguria, the Brugger's disease, IgA nephropathy. This is the most common cause of primary glomerulonephritis. Then we have nephrotic syndrome. Under nephrotic syndrome, we have hypoalbuminemia, hyperlipidemia, then peripheral edema. Then there's also massive proteinuria. The difference comes in. The difference comes in, James, kwa the cause. Nephrotic syndrome, if I'm not wrong, who idiopathic, like haina any specific cause. Na nephritic syndrome iko na nini? Iko na inakwanga nini? Your reaction, antigen antibody reaction of the surface of the glomerulus. And then Rada also says nephrotic syndrome ni acute na iko na HTN, nephrotic syndrome ni chronic na iko na hypertension. So I hope to saw that one. So to the letter number 86, systemic effects of burns include A, hypovolemia, generalized vasoconstriction. B, decreased cardiac output, bronchospasm. C, hypotension, peripheral vasodilatation. D, decreased capillary permeability and hypovolemia. So let's set the answers for number 86. So number 86, naona tunasema C, except block portion 2 says A. So A is hypovolemia, generalized vasoconstriction, and C is hypotension, peripheral vasodilatation. And Bobby also says A. A is hypovolemia and generalized vasoconstriction. James also says A. Okay, so we have two contradicting answers. So maybe we can get some evidences and go through it on the systemic effects of burns. So there's another one. There's an evidence sent here by Wildflower. So the systemic response. So we have renal system. Under the renal system, we have vasoconstriction occurs due to loss of fluid from the intravascular compartment, and this results in reduced renal plasma flow and decreased and depressed glomerular filtrate. So tumeona vasoconstriction iko. And then we also have oliguria, This needs urgent fluid replacement to prevent acute renal failure. So under the renal system, we have vasoconstriction, oliguria. Then we also have BUN and creatinine elevated due to tissue breakdown, decreased circulating volume, and oliguria. Hematuria may be evident due to increased red blood cell hemolysis. If it is electrical injury or myoglobinuria occurs, which occludes the kidney tubules, hence high risk of renal failure. Okay, so on the GIT, we have generous peripheral vasoconstriction. So you know that vasoconstriction is also there. Vasoconstriction in the GIT of the burn shock, so that only vital organs receive blood flow, causes decreased GIT perfusion. So gastric acid production is initially suppressed for 43 to 72 hours for injury and then surpasses normal level due to released catecholamines, and these may cause erosion and also ulceration. Gastric ileus may occur as digestion ceases, necessitating the placement of NGT for gastric decompression and until motility is reestablished. So under the cardiovascular system, immediately following a burn, there is a burn shock in which there is precipitous drop in cardiac output that is 50% caused by myocardial depressant factor that directly affects the contractility of the heart muscle, the local response. That is, the fluid losses, increased capillary permeability, and vasodilatation decreases circulating volume. If fluid volume is not replaced, cardiac output continues to decrease, resulting in inadequate perfusion, organ dysfunction, and death. Then Bobby says immediately after a burn injury, vasoconstriction occurs in the surrounding area, the burn to limit blood loss and to contain the injury. It is an initial compensatory mechanism. I've sent something here. So cardiovascular effects of the burns, we have hypovolemia, cardiac depression, decreased cardiac output, burn shocks up to 48 hours. The vascular effects, we have increase in capillary permeability. There is sodium and protein leak into the interstitium tissue edema. Then we have the respiratory effects. We have bronchoconstriction and ARDS. Peripheral and splanchnic vasoconstriction. We have AKI, alias, GA stress ulceration, and then we have under fluid resistation. There's tissue edema, there's pulmonary edema, and abnormal compartment syndrome. This systemic inflammatory response to injury, HPA axis activation, we have increased ADH, sympathetic nervous system activation, increased RAAA, then hypercoagulability, then we have hyperalbuminemia, hypermetabolic phase from 48 hours up to 1 hour, up to 1 year, that is catecholamines increase, cortisol and glucagon all increase. There's a decrease in insulin, increase in hepatic gluconeogenesis, glycogenolysis, lipolysis, proteolysis, hyperdynamic circulation, hypothermia or increased oxygen consumption, weight loss, muscle weakness, immune suppression, impaired wound healing. So thank you for that, guys. So from the evidences to Mona, so which answer is which? Is it A or C? So it's not only the why not B, and Tushel says from these is still C. From your evidence imekuwa hapo juu it's still C. So your phone is atuangalia payment call in the meantime to confirm the answer. So the correct answer is A. Burns affect the integrity of the skin. This leads to excessive fluid loss, which leads to decreased circulatory volume. This can cause hypovolemia and hypertension. The compensatory response to the reduction of secretory volume is vasoconstriction. So I hope you guys meona it's A. Now I hope mko sawa to CT to the next question. Unaweza tuma number 87 tuendelee. The ovarian cycle. The ovarian cycle occurs in the following phases. Follicular ovulation, luteal. B, proliferative ovulation, secretory. C, menstrual proliferative, secretory. D, ischemic, luteal, and proliferative. So which is which for number 87? It's A, follicular ovulation and luteal phase. So the titular anauliza what B's? Bobby says C in menstrual phase. That is the menstrual proliferative and secretory phase. So see tuendelee to the next number. Gisheru ana request kama mtu ako na picha ya ovarian na menstrual cycle atume, na tuchelo na question kama A sio menstrual cycle. It's ovulatory, yeah. Unaweza tuma number 88 tuendelee. 88, the air conditioning system and the fumigation of the operating suite in theater mainly. A, prevents equalization of air pressure. B, controls humidity. C, minimizes manipulation of microorganisms. And D, enhances utilization of gases. So number 88, I'm saying is go with C. That is minimizes multiplication of microorganisms. Unaweza tuma number 89 tuendelee. So there's a picture of the follicular and the of the ovarian and the uterine cycle. That is a menstrual and the ovarian cycle. So ovarian cycle phases, we have the follicular phase, the luteal phase, and the follicular and the luteal phase. Under it we have selected tertiary follicles, covulation, corpus luteum, corpus albicans, and then degenerated corpus. Under the uterine cycle phases, we have the menses, proliferative phase, and the secretory phase. So unaweza ona days zenye menstruation ukaa hapo hivyo kwa hiyo phase. Zimekuwa marked hapo hivyo 0 to 7 menses, then proliferative phase is 7 to 14 days, day 14. Then secretory phase is from day 14 to all the way to day 28. Tuchilo, I hope uko good, uko sawa hapo. Number 89. Buffers of human body circulation include A, phosphate, carbonic acid, and proteins. B, proteins, carbohydrates, and phosphates. C, carbohydrates, carbonic acid, and phosphates. D, proteins, carbonic acid, and carbohydrates. So let's send in our answers for number 89. So number 89, I'm seeing us go with A. Any phosphates, carbonic acid, and proteins. Na Bobby anasema carbohydrates hakuna. Okay. So nasema bicarbonates, hemoglobin, proteins, and phosphates. Okay, so tuendelee to number 90. Let's continue to number 90. Uh, 90. The common cause of atypical pneumonia is A, cytocosis. B, mycoplasma. C, Legionnaires, and D is E. coli. So let's send in our answers for number 90. Number 90, I'm seeing us go with B. B is mycoplasma. So tuko sawa hiyo na B. Number 91. Management of patient with myocardial infarction includes A, moderate physical activity, high calorie diet, then B, low sodium diet and low fiber diet, C, supine position, high calorie diet, D, low calorie diet, bed rest. So how do you manage a patient with myocardial infarction? That's the answers for number 90. 91. In the meantime, let's read something on these types of pneumonia. Pneumonia, hospital acquired, develops greater than 48 hours after hospitalization. And then ventilator associated. This one is subsequent of hospital acquired, develops more than 48 hours after ventilator use. Then we have the community acquired, develops outside of the hospital. Then hospital acquired is treated with methicillin. Causes methicillin resistance of the cause is methicillin resistance of Staphylococcus aureus. Ventilated associated is Pseudomonas aeruginosa and Staphylococcus aureus. Community acquired, we've seen that one. Then we have the typical pneumonia caused by Streptococcus pneumoniae, Haemophilus influenza, Staphylococcus aureus. Typical pneumonia, aka walking pneumonia, mycoplasma. Pneumonitis mycoplasma. Yeah. Just from the answer that we from multi options, we're saying mycoplasma, the chlamydia and legionella pneumophilia. Okay, there's another one sent there by Staphylococcus. So 91, I'm seeing B and D. And B is low sodium and low fiber. D is low calorie diet and bed rest.
So how do you manage myocardial infarctions? So low fiber diet means patient will have constipation, which will lead to arrhythmias. That's why they are managed with laxatives. And then Zoo says low fiber diet. With low fiber diet, the patient will constipate and strain the heart. There's the same thing up there. So see, okay, Bobby says A. Bobby says A. Okay. So unaweza tuangalia med scholar pia U4. So low fiber diet, low sodium, low fiber diet. Sodium restriction is good, but low fiber diet is necessary or recommended. So unaweza tuangalia med scholar inasema nini pia. Med scholar says the correct answer is D. Myocardial infarction is a condition in which there is inadequate blood supply to the heart muscles, leading to ischemia of the heart muscles. A patient with myocardial infarction should take the following diet: that is low sodium, low calorie, high fiber to avoid constipation that can lead to straining. Also, the patient should be on bed rest to avoid increasing the work of the heart. So just from what colleagues wamesema hapo juu tumeona Dave anauliza low calorie juu ya nini? So nursing mnemonics and tips, immediate treatment of myocardial infarction. So we have the mnemonic is MONA, TAAS, MONATAS. So M stands for morphine or oxygen and nitroglycerin. A aspirin, T thrombolytics. A anticoagulants, S stool softeners, and then S is also sedatives. So Dave amejibiwa hapo locally diet, particularly if the patient is overweight or obese, to reduce metabolic demand and promote cardiac health. And then atherosclerosis is common cause of MI. Moderate physical activity at least 30 days is recommended. So number 91 tumeona it's D, unaweza tuma number 92 tuendelee. Dave, I hope uko sawa from the question that you asked up there. Number 92, the following statement describes mode of action of digoxin. A, it increases the heart rate and reduces contraction force. B, it reduces heart rate and increases contraction force. C, it reduces hyperkalemia and increases peripheral circulation. D, it increases cardiovascular circulation, increases metabolism. So let's send in our answers for number 92. The kid says B, it's inotropic na coronotropic. So number 92 is obviously B. Tumeipitia over and over again, digoxin. It's a common question. It increases the heart, it reduces the heart, it increases the contraction force. So to Rudy, let's go back to number 90. Let's go back to number 90. So number 90, the common cause of atypical pneumonia is, so kuna hii evidence hapa hivi. Kuna hii evidence hapa hivi. Number 91. Number 91. Number 91. Unaweza soma penye umechanganyikiwa number 91. So number 91, management of a patient with myocardial infarction includes unauliza hii kusema low calories bado calories si energy content ya food ama plus the term moderate physical activity at least 30 minutes is recommended. So tusaidie Dave hapo, anasema he's a little bit confused hapo number 91. He needs some clarification on the reason why the patient should get low calories. Calories is needed for energy. So tuendelee number 93. One of the following is not a structure of the vulva: A. Labia minora, B. Mons veneris, C. Bartholin's gland, and D. cervical os. That's the cervical lobe or os obviously. Unaweza tuma number 94 tuendelee. The part of the blastocyst that develops into the placenta is A. Inner cellmus, B. Trophoblast, C. Blastocyst, D. Cytotrophoblast. So number 94 ni trophoblast. It's B. Yeah. Now, inner cellmus develops into what? What does the inner cellmus develops into? And then Bobby says cytotrophoblast are just cuboidal dividing cells. The inner cellmus develops into the embryo. So, tuma 95 tuendelee. 95. The probable signs of pregnancy include a fetal heart tones and quickening. B, we have the Hager sign development of the fetus. C, we have nausea and vomiting. Then D, amenorrhea and vomiting. Singers go with B. B is Hager sign and development of the fetus. Yeah, so hiyo tuko sawa. Tumezipitia zile pia na plus the signs, the positive, the probable and the presumptive. We've looked at them over and over again. Unless kuna mse anataka any clarification on them, tunaweza ziangalia tena, tunaweza zipitia juju. Should we go through them, the probable, the positive and the presumptive signs of pregnancy? So tuendelee number 96. Tuma number 96 tuendelee. So the inner cellmus, this one becomes the embryo on the placenta. Trophoblast forms placenta. The blastocyst is a development stage, not a specific structure from the placenta. Cytotrophoblast are part of the trophoblast, but the full trophoblast, including schistotrophoblast, forms the placenta. So, tuma number 96 tuendelee basi. Can listen number 96. This is number 95 hapa. Yeah, presumptive ni more subjective. Yeah, so then the rest are objective, are more objective. 96. The main focus during the fourth antenatal visit should be A, birth preparedness, B, history taking, C, fetal growth monitoring, and then D, danger signs in pregnancy. That is A. Toma 97 tuendelee. 97, an 18-year-old Premigravida is admitted at 34 weeks gestation with preeclampsia. The nurse should observe her carefully for signs of eclampsia, which include a rise in systolic blood pressure of 30 milligrams of mercury or more, B, convulsions, seizures, and coma. C, we have a diastolic blood pressure of 90 milligrams of mercury or more, and D, proteinuria 3+. So it's B. Those are obviously the signs are preeclampsia. So tuma number 98 tuendelee. 98. A woman who is 32 weeks gestation has had ruptured membranes for 26 hours. A nurse would assess the woman for the following manifestation: A, proteinuria, B, dependent edema, C, constipation and elevated temperature. Obviously, lazima assess for sign of infection, and the sign of infection would be D, elevated temperature. So there are these probables, there are these signs of pregnancy. So the possible signs kuna vitu kama early breast changes, which occurs 3 to 4 weeks, and then amenorrhea 4+ weeks, nausea and vomiting 4 to 14, body irritability 6 to 12, and then quickening 16 weeks plus. Those are the possible signs. And then probable signs is the presence of SCG, softened isthmus, which is the Hege sign, bluing of the vagina, that is the Chadwick sign, pulsation of the fornices, that is Lucienda sign, and then changes in skin pigmentation, uterine sulfur, then we have Braxton Hicks contractions, then ballotment of the fetus. Positive signs of pregnancy, we have the visible of the visualization of the gestational sac by transvaginal ultrasound, transabdominal ultrasound, visualization of the heart pulsation by transvaginal ultrasound, transabdominal ultrasound, then fetal heart rate, fetal heart sounds by Doppler, fetal scopes, then fetal movements, palpable and visible, fetal parts palpable too. So tumeona that. So tuendelee to number 99. Kindly send number 99 tuendelee. The management of hyperemesis gravidarum includes A, antibiotics, psychological support, B, psychological support, correct fluid and electrolyte imbalance, C, correct fluid and electrolyte imbalance and antibiotics, D, encourage oral fluids and antiemetics. So kuna kati ya D na B. So how do you manage a paremesis gravidarum? Tunaweza tuma some evidences on this one to EPTA. Okay, what do we give? Do we give antiemetics, or do we just provide psychological support? Is it more physiological or psychological? Because B test more of the psychological support, test more of the psychological aspect of the disease, and then D test more of the physiological, especially on the antiemetics part. So what's the priority? Let's look for something about paremesis gravidarum to PTA, the management. So Papa Nasama, it's considered a major condition in pregnancy, so we treat. And then Babi says oral fluid to lot is the nausea and vomiting. Tuchel says antiemetics will. So your phone is a tuma ya Medscola. There is a tuma ya Medscola tuiangalie. Paremesis gravi okay, naanzia nitaanzia wapi? Let's just go straight forward to the treatment. So the aim of treatment is not only to stabilize the woman's condition, but also to prevent further complications. Continual vomiting during pregnancy may lead to vitamin deficiency and or hyponatremia, which can present with confusion and seizures, leading ultimately to respiratory arrest if left untreated. For women who are immobilized through the severity of vomiting, deep venous thrombosis is also a potential complication due to combination of dehydration and immobility. In cases of hyperemesis gravidarum, the fetus may be at a risk of being small for gestational age due to lack of nutrients. So mi nadhani you treat it. So you give oral fluids na antiemetics. Meanwhile, your phone is to confirmia medical inasemaje. So it's over after Williamson. Is that Williamson? I'm seeing you Williamson, James. I'm not seeing that Williamson. Oh, so this requires treatment in hospital where intravenous fluids are given, okay, to reduce the woman and correct electrolyte imbalance, with antiemetics being administered to control vomiting. Oh, okay, so iko clear hapo. But scholar says the correct answer is B, psychological support, correct fluid and electrolyte imbalance. So the management, hospitalization, whenever a patient is diagnosed as a case of paremesis gravidarum, she is admitted. Fluids, all fluids is withheld for like 24 hours after cessation of vomiting. During this period, fluid is given intravenously. Drugs, antiemetic, promethazine, metoclopramide, ondansetron, hydrocortisone, hypertension or intractable vomiting. But pia ina support hiyo point ya nini, Yeah, antiemetic, so I don't know. The nutritional supplementation with vitamin B1, vitamin B6, vitamin 6C, and vitamin B12. We also have the nursing care, the diet. So tuendelee. Uh, tuendelee na B ama D. Utaweka B ama D, then you'll star. Number 100. The mechanical factors that facilitate the progress of labor during the first stage are A. General fluid pressure, fetal axis pressure, B. Cervical dilatation, fundal dominance, C. Polarity, cervical dominance, D. Fundal dominance and polarity. Let's send in our answers for number 100. Uh, 100, I'm seeing us go with A. A is general fluid pressure, fetal axis, and fetal axis pressure. So then kuna mtu anauliza, the Bobby asked Dini what factors? The fundal dominance and the polarity. Oh, so uterine factors. Okay. So fundal dominance and polarity, they're uterine factors. Thank you for that. Trend number 101. The action of oxytocin on the uterus is by. The action of oxytocin on the uterus is by A. Inhibiting spontaneous contractions of pregnant uterus. B. Contracting the pregnant uterus but relaxing the cervix. C. Causing regular coordinated uterine contractions followed by relaxation. And D. Causing contractions with an increase in basal tone. Let's send in our answers for that number 101. So 101 naona tunaenda na D. D is causing uterine contractions with an increase in basal tone. So the other factors, other uterine factors include contraction and retraction, intensity and resting tone, formation of the upper and the lower uterine segments, retraction ring, and appearance of show. So 2102. 2102, 101 ikiwa D. 102 on vaginal examination during labor, the midwife should document the following about the cervix. A. Effacement, ischial spines and dilatation. B. Effacement, position, dilatation. C, position, ischial spines. Dilatation. D, effacement, ischial spine and positions. So let's send in our answers for 1 or 2. So si ischial spines itatoka juu iko kwa as in juu iko kwa cervix, so that means we'll remove the ischial spines. So that leaves us with B. Yeah, so that leaves us with B. Tumo na 3 tuendelee. When diagnosing abruption placentae, the midwife should take the note of the following. So, what should you do when diagnosing abruption placentae? A, absence of pain on abdominal palpation in reveal type. B, fetal parts can be palpable, can clearly palpated, and there's no fetal heart rate in concealed type. C, the uterus is tender and rigid, and pain constant in the combined type. D, the pulse is raised and there's low blood pressure or hypertension on the concealed type. So listen to no answers for 1 or 3. One or 3 now tunaenda na B, that is a fetal parts can clearly palpated and there is no fetal heart rate in concealed type. So if maybe unaweza tuangalia med scholar so that we can confirm it. Tuendelee. My target need to fike at least 50 questions this session. We are like 40 something questions. Tukifika 111 tutafika 50 questions. So tuendelee tu. So med scholar says the correct answer is C, abruption condition in which placenta is separated. Abruption condition in which placenta is separated from its normal bed completely or partially before delivery. The following are features of placenta abruption: purvaginal bleeding in reveal type. In the concealed type, purvaginal bleeding may not be present. Patient presents with increased heart rate and hypotension, difficult to feel palpable to feel fetal parts. Then the patient has abdominal pain. This occurs in retroplacental bleeding. Lower abdominal pain as the blood irritates the uterus. Then the fetal distress due to impaired placental function. If bleeding is severe, it can lead to hemorrhagic shock. So that's that. Now ukifanya examination, kuna the vital signs, normal if minimal bleeding, sense of shock in severe bleeding. Then abdominal examination, we have the fundal height equivalent to the gestational age, unless in reveal type, but can be more in concealed type. Then we have uterine tenderness, fetal distress. Then the uterus also may be hypertonic and contracted. On vaginal examination should not be done until placenta previa has been ruled out. So kuna hiyo difference ya previa na abruption. In the bleeding, for previa it's always painless, not attributable cause, then it's bright red in color. In abruption, this one is painful, may cause preeclampsia, trauma, and blood is dark colored. In anemia, proportionate to blood loss, but in abruption, outer proportionate to blood loss, especially in concealed type. The fundal height is proportional to gestational age, while in abruption, proportional in reveal, but can be more in concealed type. The uterus is often contracted in the previa, while in abruption, the uterus is tender and firm due to blood irritating it. Malpresentation is common in previa, while in abruption is not common. Then location of the placenta is in the lower uterine segment. Then it's in its normal site in abruption. So So tuendelee na 103C, unaweza tuma 104 tuendelee. One four. The features of a midwife will find the features of midwife will find on examination of the bregma in a newborn include: A, diamond shape lies at the junction of the frontal suture, pulsation. B, diamond shape, pulsations, large membrane space. C, large membrane space lies along the coronal sutures and pulsation. D, does not pulsate, irregular shaped and large membrane space. Tushel, swali gani nauliza nini? So 104 naona tunaenda na A, which is except naona B moja. So A ni diamond shaped, lies at the junction of the frontal suture, a pulsation. Then B ni diamond shaped, pulsation, large membrane space. So which is which? Kati ya A na B. Na pia unaweza tuangalia Med Scholar 104. Unaweza tuangalia Med Scholar. For the correct answer is B. The bregma is an anatomical point where the coronal suture meets and the sagittal suture in adults. It's also called the anterior fontanelle in children. So the following are the features of the anterior fontanelle. The anterior fontanelle is diamond shaped. It pulsates. It's a large membranous space. Then it measures about 4 centimeters in its anterior posterior position. It measures 2.5 in its transverse diameter. Then it closes between 18 to 24 months. And B, triangular shaped fontanelle is the posterior fontanelle. So Baby says the bregma lies in the junction between the sagittal, coronal, and the frontal sutures. So I hope to convince 104 ni B. Because 104, yeah. So 105. Meconium is completely excreted within A, 12 to 24 hours. B, 24 to 36 hours. C, 36 to 48 hours. And D, 48 to 72 hours. That's the no answers 4 and 5. silikuwa 24 to 48 hours. Nikikumbuka poa. 24 to 48 hours. So normally meconium is passed within the first 24 to 48 hours after birth. Complete excretion of meconium typically occurs by 48 to 72 hours. Okay, so completely inaisha within 48 to 72 hours. Na initial passage inaoccur within the first 24 hours. So 15D unaweza tuma 16 tuendelee. That's 15 again. Unaweza tuma 16. On 6, deaths of newborn that occurs within the first week of life are classified as A, infant death, B, fresh stillbirth, C, perinatal deaths, and D, neonatal deaths. So is it perinatal or neonatal deaths? Tushel says perinatal, 28 weeks to 1 week of life. Emmanuel says early neonatal death occurs within 0 to 7 days. So ni neonatal ama perinatal death? Neonatal death, there's the death of live-born infants within the first 28 days of life. Early neonatal deaths occurs within the first 7 days of life. Late neonatal deaths occurs from 8 to 28 days. So it's a neonatal death. Perinatal ni ile ina include from 28 weeks of gestation to 7 days of birth, unless I'm wrong about it. Unaweza tukonfirmia pia comment scholar tuone what's the correct answer. So perinatal includes stillbirth, especially late ones, and early neonatal deaths, usually up to 7 days. So the correct answer is D, neonatal deaths. 107, tuendelee. Tuma 107. Medscholar says it's neonatal death. So neonatal death ni yenye inaoccur during the first 28 days of life, na inakuwa divided into the early neonatal death, which occurs from birth to 7 days of life, then the late neonatal deaths, which occurs from 8 all the way to 28 days of life after birth. So na perinatal ni hiyo tumeona from 28 weeks of gestation to the first week of life. 107, autolysis is the process by which a uterus contracts and retracts to reduce in size. B, lactation is established. C, muscles have insufficient blood supply. D, proteolytic enzymes digest the muscle fibers. So I think it's D, proteolytic enzymes digest the muscle fibers. 107 is D. Unaweza tuma 108. 108. Preventive measures of pulmonary embolism in pupidium include: A. Careful aseptic technique. Prenatal exercise. B. Prompt identification and treatment of affected limbs. C. Prenatal exercise, early ambulation. D. Careful aseptic technique and use of anticoagulant. So which is which? It's C, yeah? Prenatal exercise and early ambulation. So unaweza tuma 109. In the third degree inversion of the uterus, A, the cervix is inverted and visible at the vagina. B, the fundus of the uterus is inverted and is at the internal os. C, both the uterus and cervix are inverted and the vagina are inverted and are visible. D, the body of the uterus is inverted to the internal os. So let's send in our answers for 109. So naona tunaenda na C na B. C is both the uterus and the cervix are inverted and the vagina are inverted and are visible. And B is the fundus of the uterus is inverted and is at the internal os. So which is which? Kati ya B na C. So tunaweza pata some evidence on it. We don't need to waste a lot of time. Kama tunaweza pata evidence tuipitie mbio, it will be better. Yeah, plus the other types. So the first degree is incomplete. The fundus is inverted but remains inside the uterine cavity. The second degree complete. The fundus passes through the cervix but remains within the vagina. The third degree, the entire uterus and the cervix are inverted and protrude through the vulva. The vaginal walls may also be involved. The fourth degree, that is the total inversion. The uterus, cervix, and the part of the vaginal canal are inverted and protrudes outside the vulva. So from mere evidence, med scholar, some of the correct answer is A. Med scholar, some of the correct answer is A. Ilikuwa the cervix is inverted and visible at the vagina. So tuangalie the first degree, the fundus reaches the internal os. Second degree, the body of the corpus of the uterus is inverted to the internal os. The third degree, the fundus protrudes to or beyond the introitus and is visible. The fourth degree, this is the total uterine and vaginal inversion, where both the uterus and the vagina are inverted beyond the introitus. So from here tunakubali na med scholar kweli. Kuna mtu close topic. Kindly reopen it, tuendelee. From those evidences that we've sent, tunakubaliana med scholar. Ama what's our answer? So any answer, end answer. Sini fourth from Miles. So tuendelee, unaweza tuma 110. Kindly send 110 tuendelee. So 110, 1 week neonate is brought to a health facility will receive. A 1 week neonate is brought to the health facility will receive Sini birth polio na BCG, that is C. And that's straightforward. Hiyo tuma 111 ziko 50 questions. 111. The advantage of IUCD include a highly effective, offers long-term protection and prevents ectopic pregnancy. No. B, highly effective, pelvic examination not required, protects endometrial cancer. No. C, offers long-term protection, requires pelvic examination and prevents ovulation. D, easy to use, highly effective, rapid return of fertility upon removal. C, D. Yes, 111 is D. So we've come to the end of our session today. Imekuwa a very nice session. Thank you guys for your participation. Now, in your book for updating our score sheet, for sending the questions, and everybody who has actively participated. Thank you guys, and let's keep the spirit up. Kuna mtu anauliza difference ya outbreak na epidemic. Okay, so from what I know, naweza sema an outbreak is like a sudden rise in number of cases of a disease kwa specific area, like kwa specific geographical area ama kwa population. Lakini epidemic ni widespread occurrence of infectious disease in a community, region or area. Example naweza peana ni ya outbreak ni kama kitu kama salmonella typhoid occurring at a wedding, labda uliattend wedding then umekuwa na food poisoning, then typhoid occurs, ama measles outbreak. So that's an hiyo ni outbreak, an example of an outbreak. Then epidemic ni kama vile Ebola do occur in West Africa, ama seasonal flu. So that's how I'd describe it. So tuombe tumalize basi. Yeah, let's pray. Dear Lord, we come before you this evening again. We thank you for the discussion that we have had. We've had. May you continue granting us your grace. Keep us protected. Guide us even as we revise for exams and as we prepare for exams. Give us your knowledge and understanding. As we're going to sleep, protect us throughout the night. Give us life so that we can meet here tomorrow again and discuss. May what we discuss not only bring joy for be fruitful to us on the day of exams, but also throughout our practice in life. In Jesus' name I pray, trusting and believing. Amen.